Thank you, Sandeep, for kind words. I do receive research grant support from Alcon Laboratories, but has no financial interest in this patient's. Can I move to the next one, please? Right. I think this is very important. And all the experts already have given a lot of tips how you reduce that. But before I talk, I just want you to put this slide here, and please read this article which was published in 2014 by the Cataract Clinical Committee members at that time on indications and contraindications of multifocal IOLs, and you will be able to reduce that. This is not working here. The mouse is not working here. Can I go on the other side? The mouse. It's not moving forward. Which one? How do I move forward? Forward.
This one.
This one. Forward? I want to move forward. I don't want the light. All right, I'll do that. What? I think, first of all, when the patient comes, and your assistant will tell you, this patient is waiting there and he's the next one to come, be prepared. He's very, not happy. Our staff knows that this patient is not very unhappy. So understand the reason first when he comes, and whatever the reason, please and please repeat several examinations. Some of this you already have done it. You look them carefully every time, even if you know you're not going to say anything more. Keep doing all this examination and see with different angles, different technology, and if you don't have it, send it. I'll get this new scanning technique or imaging. But whatever, please look for the following common reasons. Number one, in my experience, is the residual refractive error ametropia or residual astigmatism, and I keep doing this from time and time. I'm not improving terribly well on that, I must say. So that's the commonest reason in my experience. Second is the meibomian dysfunction, the tear film, and some parts of our country you will have more than others. Slightest opacification, like high myope, bothers the patients with same degree of PCO in myopes or these multifocal would bother them more compared to the healthy retina and monofocal. Third is the IOL centration, and that some bags are not compatible and some lenses designs are that they don't remain centered after a period of time. And then the macular functions, and finally, there are personalities will never understand neuroadaptation. This is an executive typical example, wanted to get rid of glasses. So when I said Restore Plus 3, this is a representative of a traditional multifocal. And that's what I'm going to talk today on the unhappy patients, on traditional Suhas and others say shade. What are the other solutions? So patient is upset that I still have to need glasses. What are you saying? I thought, I paid this much in multifocal. What is it? And I can't see that well at distances anywhere. Whatever you say, his unaided is 6.9 and N8, and best corrected is 0.5 sphere with 0.75 cylinder. And that's what is we want to understand, that residual ametropia. So we learned that residual ametropia, refractive error, is the most common cause of the dissatisfaction of the patients. Now, preoperative expectation management, and he would expect that because I'm putting this IOL which is designed to remove the handicap, why should I wear the glasses? So we must try right before he even considers multifocal that we can only try, and honestly, majority of the patients would need to wear glasses for some activities. If you're doing 10 activities, 1 or 2 activities would need to improve the quality of vision and things like that. So you must tell them and tailor and make him realistically expectations. So we are not finally, we don't have everything in our hand. And there's nothing like zero. Or doctor, I've been to the other colleague and he said, you put toric lens and still there is this much of astigmatism or this much. Your surgery, the calculations are wrong. Tell them that if you measure these objectively, you will find some. But generally, most of the patients don't need to wear that little small degree of refractive error. So tell all this in the counseling. 68-year-old financial expert with same situation, same traditional multifocal. Well, I can see, but it's not very crisp. And the Economic Times, oh my God, this is my, I don't know whether you know it, but all the newspapers are in a white paper. For some reason, Economic Times comes in a yellowish tint. And even with the most healthiest, they won't find it easy to read. And this is the guy who would read Economic Times and no other magazine. So it's okay, but it really needs an extra illumination. So, but I can't go with headlamp on my forehead. You say extra, I can control in my office, but I'm a marketing, I have to go and visit so many people. So tell them that you will have a reduced contrast sensitivity. What does it mean? It means many things, including what you're saying. So bring it to the notice. And this is the slide I borrowed from late forgot, the great American teacher who just recently passed away, Roger Steinert. Roger gave me the slides many years ago. This is the contact lens literature, but it describes so well. On the up left is the sharp blur and illuminance. That's what happens when you add and defocus 1, 2, and 3 diopter to your image, and that's exactly will happen on your traditional multifocal, and you can understand that can never be that sharp or blur, and that's the reason the vision is not crisp if you're really very fastidious. So give them a predictive instruction, forthright, that you will have a new reading distance. You may be myopic and you think it's my birthright to read this one, and you need extra illumination, whatever the thing is, and do not look for problems. Why? Because, doctor, when I look to the bulb, I see the halo. Did you look at that bulb ever before you had in your life? Why now that post-operatively you want to look at the bulb? They never looked at the light earlier. Now you want to test everything. They want to test every aspect of what you did because they paid quite a bit. Post-diffractive implantation complaints. Sometimes I see clear, sometimes I don't, and that's where you want to see it's fluctuating. And the common sense would be to see the environment, and tear film instability is a very, very, very important cause of that. And this is another one. A singer, a professional person, I can't face the lights from the stage anymore. And when he's on the stage or a podium, that's why I didn't have a multifocal, but I asked him to shut the lights when I came here. But I'm okay, I'm still a normal lens. Multifocal IOLs lead to glare and health, and Suhas said that. So forthright discussion on the precision and flexibility. You can't have stars and moons, you will have to pay the price. And this is once again an engineer. It's not very crisp vision. Good unaided 6, 6, and 6. So that's where my colleague Samresh taught me the value of aberrations and to determine that preoperatively optical profile and the axis and sort of thing. And if there is a disparity between the visual axis and the center of the optic or the pupil, you will have lots of problems, and as this patient has. So in simple words, if the angle alpha is more than 4 or 4.5, do not consider multifocal lens, generally speaking. So when the patient comes, always listen and ask them again. If they've forgotten to complain, do you get that also? You do, oh, you don't get that. Oh, it's good, because sometimes you get that also. So ask them, make sure that you have asked him and drained him of his all that, and reassure him. And there is a very nice article, if you want to understand neurosensory adaptation with the contrast imaging. They will show you immediate adaptation, and then the gradual brain adjustment will take 6 months. So wait for 6 months before you consider, and do not shy away from that, and always learn from the fellow eye. And this is the final slide. I somehow have not been able to, I've not done explant, but I have many patients who could have been explanted. Taking time, and if your patient is a long-standing patient, he trusts you and believes you, and you say, I'm sorry that it didn't work out because the biometric measurement machinery is not that precise. We thought you will be, but this is one of those things. I can do that, but I would suggest it needs second operation, and this little glasses, you want glasses all the time, you wanted not to have, but I would think, consider, and most of the time, we are lucky that the patients are very kind to us. Not because that we are more experienced how to handle this, but the patients are very kind to us and they forgive us. So thank you so very much.